Good evening, everyone, and welcome to Tumors and Treatment, the evolving role of genetics in cancer care, brought to you by Cancer Wellness Center and the Norton and Elaine Sarnoff Center for Jewish Genetics. My name is Savina Chacheva, and I'm the Program Director at the Cancer Wellness Center. I'll be moderating this evening's lecture. With us this evening, we have Judah Gavant, Program Coordinator at Norton and Elaine Sarnoff Center for Jewish Genetics, who will share more about his organization and the incredible work they do. Before we get started with our lecture, we would like to tell you a little bit more about our organizations. For those of you who are joining us for the first time, I would like to share more about the Cancer Wellness Center. The center was founded in 1989 as a nonprofit organization with the mission to help anyone touched by cancer find a way forward. Each year, our free counseling services, support groups, health and nutrition programs serve over 2,000 community members of all ages and backgrounds. People with cancer, family members, friends, and caregivers all come to us to connect and cope. Our services, which are both virtual and in person, include education programs like the one this evening that aim to help you navigate the varied challenges that come with living with a cancer diagnosis. Wellness classes like yoga, meditation, nutrition, exercise, and more that provide a holistic approach to healthy living. And support services including counseling for individuals and families, couples, children, and those bereaved, as well as support groups that are designed to help our participants manage the mental and emotional impact of cancer. If you would like to learn more about the center and connect to our free programs and services, please visit cancerwellness.org, and the link will be included in the chat. And now, welcome, Judah.
Thank you, Savina. And like Savina said, my name is Judah Gavant, and I serve as the program coordinator at the Sarnoff Center. And the Norton and Elaine Sarnoff Center for Jewish Genetics mission is to serve as a genetic healthcare resource for the Chicago Jewish community by raising awareness of recessive genetic disorders and hereditary cancers that are more common in the Jewish community. The Sarnoff Center provides education for individuals, clergy, and healthcare professionals, and offers low-cost genetic screening for individuals and couples planning a family. More information about the Sarnoff Center can be found on our website, jewishgenetics.org. We'll have time for Q&A at the end of tonight's presentation, so please feel free to type your questions into the Q&A box throughout the session. To keep the discussion relevant and helpful for everyone, we kindly ask that questions remain general. While we're unable to provide personal advice during the webinar, please contact us afterwards if you'd like to discuss your individual situation. And now I'm honored to introduce our speakers for tonight. First, we'll have the opportunity to hear from Dr. Shari Snow. Dr. Shari Snow is Chief of Gynecology and Minimally Invasive Surgery at University of Chicago with a clinical focus in minimally invasive gynecologic surgery, complex menopause, and hereditary cancer syndromes. In addition to her clinical practice and Chief of Gynecology duties, Dr. Snow serves in a leadership role at University of Chicago as Associate Chief Medical Officer for Ambulatory Services, where she is responsible for strategy, access, operations, and quality measures across the enterprise's ambulatory settings for all specialties of medicine. Dr. Snow is a member of the Preventative Oncology Program at UChicago in diagnosing and caring for patients with hereditary cancer syndromes. She previously has served on the faculty for the UChicago City of Hope Cancer Genomics Conference and as a member of the Medical Advisory Board of Myriad Genetics. Dr. Snow is currently a member of the Sarnoff Center's Board of Directors. After Dr. Snow's presentation, we'll also have the opportunity to hear from the Sarnoff Center's genetic counselor, Scott Weissman. Scott Weissman joined the Sarnoff Center in July 2023. Scott graduated from Northwestern University with his master's in genetic counseling in 2002. At Endeavor Health System, Scott works with adult patients at risk for various conditions, including hereditary forms of cancer, cardiac disease, and neurologic disorders. In 2016, he opened a private genetic counseling practice called Chicago Genetic Consultants, LLC. Scott is currently a clinical faculty member at the Northwestern University Genetic Counseling Program. And now to start us off, it's my pleasure to welcome Dr. Shari Snow.
Thank you, Judah and Savina. And thank everyone on the webinar for being here and spending this evening with us. I'm going to share my slides and we will get going. All right. So thank you again, for that detailed introduction. I'm going to jump right in and we'll talk about tumors and treatment, the evolving role of genetics in cancer care. Oh, I'm hoping I can do that. There we go. So we all carry bad genes. If in our family we have cardiac disease, blood clots, stroke, or cancer, there is a reasonable chance that there is something in our genetic makeup that made us predisposed to having some of these problems. That isn't to say that there is a known genetic reason for every disease, but that there are certain propensities that we all carry. So what are cancer genes? So let's start back with what are genes. Every gene creates a protein, and that protein has a function in our body. And if the gene that creates a protein, instead of making a protein that looks like this, makes a protein that looks like this, that protein's not going to be able to function as well inside our body. When it comes to cancer genes, they typically have one of two functions. They either are involved in something called apoptosis, which is programmed cell death, when a cell is deemed to be too unhealthy or too damaged to function correctly. There are mechanisms in which these cancer gene proteins will tell that cell, stop dividing and die. The other way, and the way that most cancer genes work, is by DNA repair. So they find errors and breaks in DNA of other genes, and they will go ahead and try and fix those problems. Because otherwise, if those corrupted, broken DNA cells don't get fixed, they'll continue to divide, which can lead to cancer. And they work in conjunction. So each of these proteins work oftentimes with other proteins to be able to form complexes to be able to find breaks in DNA. So here at the top of the screen, you see in the green squiggly line, you see a broken that is not continuous. And you see that there is a number of genes, many of which are cancer genes that are involved in the process to try and fix that broken DNA. So we see BRCA1, BRCA2, ATM, CHEK2, RAD51, many others that work to BARD1 that work together to be able to form a complex, and each protein has its own function to help to repair that DNA. So a little bit more about definitions. Let's talk a little bit about the difference between germline mutations and somatic mutations. So germline is a fancy way of saying that it's in all of the cells in your body, including in your blood cells, that it is present in every cell from birth. From the time that the embryo developed, that all of those cells had this particular mutation. Oftentimes, again, those in the cancer genes that will impair DNA repair and control cell death. And germline mutations are inherited from the parent, typically, either from one side or the other. And they can be tested for, usually in a blood test or saliva test, because they are found in every single cell in our body. Somatic mutations, somatic testing, is where we take a cancer, a tumor, and we specifically test that tumor to see what mutations are there. They may, in the process of becoming a tumor, they can acquire different types of mutations that haven't been fixed, and that leads to that uncontrolled growth or that cancer. So many of the cells in that tumor will have that same mutation, but it wasn't found in the healthy cells in that person's body, and it wasn't inherited from a parent, and it's not able to be passed along to offspring. So here's where it gets tricky, that if there's a germline tumor, that germline mutation that is found in every single cell in the body, that will be found in a cancer cell too, and be able to test it in somatic testing. But not all somatic mutations are found in all the cells in our body. So with cells that are with mutations that are inherited, these germline mutations, how often do we see those in certain types of cancers? So some types of cancers have it pretty regularly. Ovarian cancer, anywhere from 19 to even up to 25 or 26% of ovarian cancer, we can find a germline or a mutation, such as the BRCA mutation, that was putting that patient at increased risk of ovarian cancer. Stomach cancer, about 11% of people will have a mutation. Breast, about 9% of people will have a mutation that we can find in every cell in their body. Sometimes in a tumor, we're able to find clues that there is a mutation that is hereditary and has been passed along. We can look at microsatellite instability. This is particularly appropriate for anyone who has a colorectal cancer or uterine cancer, that we take a look at the tumor itself and we do DNA sequencing and we test for particular mutations. And oftentimes we will find that there are numerous mutations in these short little repeated DNA sequences called microsatellites. If there's a lot of mutations, that's a clue that maybe the DNA repair system is broken. This is very suggestive that there may be a mutation in Lynch syndrome in the genes of MLH1, MSH2, MSH6, PMS2, and EpCAM. As these genes repair these damaged DNA in what's called mismatch repair. So sometimes we can look at types of cancer, and that will give us a sense that there's a better chance that we're going to find a hereditary cancer syndrome. So why is this important? Again, somatic mutations can be clues to the fact that there are germline mutations. Germline mutations may place a patient at risk for other cancers. So in the case, again, of BRCA, you will find that if someone has a breast cancer and they are found to have a germline mutation, they also have a risk for ovarian cancer. So it's important for us to understand that risk so we can keep the patient safe from secondary other cancers. Again, germline mutations, we want to find them because they have implications also for family members, because they're inherited. If someone carries a germline mutation, we can then have the rest of the family get tested to try and avoid that family member getting cancer or to detect it very early. And then also because these mutations, whether they're germline or somatic, can be used as vulnerabilities or targets for treatment. So there are two pathways that DNA gets repaired. Genes like BRCA1 and 2, PELB2, ATM, and other mutations repair damaged DNA. There is another protein called PARP, which repairs single-stranded DNA breaks. Cancer cells are really prone to DNA breaks. They're replicating or dividing very fast. And so in doing that fast division, there's not a lot of time to repair when things don't go quite right. And those accumulated mutations can lead to DNA breaks. In cells that have these impaired repair proteins, these mutations, they don't repair the damage of that DNA. And so there's more accumulation of that damaged DNA. So there's a class of medications called a PARP inhibitor that capitalizes on inherent impaired repair due to the genetic mutation. A PARP inhibitor will stop that pathway of repairing DNA. And if there's also a mutation in the other pathway, then that's considered a double hit or a lethal hit, leading to increased cellular death of the cancer cell. PARP inhibitors can be identified because they will have the last three letters of IBS in it. So it's olaparib, niraparib, the IBs. This is oftentimes treated, they are oftentimes used to treat BRCA mutation cancers such as breast, ovarian, fallopian, and prostate. They are oftentimes used in other mutations such as PELB2, ATM, BARD, BRIP1, RAD51C, and RAD51D. So in people who either have a tumor mutation or whole body germline mutation in any of these genes and have a cancer in breast, ovarian, fallopian, or prostate, the PARP inhibitors are a very potent form of chemotherapy to specifically try and inhibit the other DNA repair pathway to cause cell death. In the last few years, PARP inhibitors have been thought to be able to be used in other situations as well. So it can be used as a two-prong approach in that tumors that don't have a genetic mutation, but we can use PARP inhibitors in conjunction with other cancer treatment that increases cell DNA damage. So chemotherapy and radiation will cause damage to that DNA, and then the PARP inhibitor can impair the cell's ability to repair it. Or it can be used in conjunction with certain monoclonal antibodies, drugs that have the last three letters of MAB, rituximab, that block new growth of the blood vessels to a tumor or target the tumor for the immune system. Let's talk a little bit more about that. So these monoclonal antibodies, they're antibodies in general in our body alert the immune system that something's going on. So antibodies may find an infection and tell the immune system you have to treat this infection. Antibodies also can alert the body of a cancer cell and tell the immune system to attack that cancer cell. Antibodies can be synthetically designed to target proteins in the cancer cell or parts of the immune system itself to be able to potentiate, increase the effectiveness of cancer therapy. The benefit of monoclonal antibodies is that they're really highly specific. They pinpoint exactly where that immune system should work. And because they're so highly specific, they tend to have less side effects. One particular type of monoclonal antibody are called checkpoint inhibitors. These checkpoint inhibitors are effectively the linebackers of the linebacker concept of treating cancer. What they do is they basically will tag the cells and that turn off the immune system from attacking the cancer cells. So by tagging your own immune system and saying, don't go any further, it allows that immune system to go full force in trying to fight those cancer cells. It's been used often now in breast, bladder, head and neck cancers, kidney cancers, melanoma, and some lung and blood cancers. It is especially effective in Lynch syndrome because there's a lot of small mismatch mutations in the DNA that really trigger immune system recognition. So Lynch syndrome cancers, such as colorectal cancer, uterine cancer, due to a mutation in MLH1, MSH2, MSH6, PMS2, these particular cancers are great targets for these checkpoint inhibitor monoclonal antibodies. So pivoting just a little bit, I'd like to go over some news for people who have a germline mutation, a hereditary cancer mutation, from the NCCN, or National Comprehensive Cancer Network. The National Comprehensive Cancer Network is a consortium of about 30 academic medical systems throughout the country that come together every year to make all of the recommendations for all things having to do with cancer. It has to do with what medications or treatments should be considered for each type of cancer. It says who should be screened for hereditary cancer testing, and it says what should be done in trying to protect people who have a propensity for cancer, hereditary cancer mutation. So one of the recommendations that is new in 2025 from the National Comprehensive Cancer Network is what to do as far as screening after someone has had a mastectomy in hereditary breast and ovarian cancer. So hereditary breast and ovarian cancer are genes such as BRCA, PALB2, and some patients have chosen to do a mastectomy afterward, after finding out that they are BRCA or PALB2 positive. And in that case, the question is, they don't have a 0% risk of having a breast cancer, so how do we monitor them? We now have guidance that for these patients, self-breast exams should be taught and encouraged. They should come in yearly for a physician or provider to do a clinical breast exam, a breast exam in the office, and that it affirms that there is no recommendations for MRI or mammogram to be performed. Mammography and MRI are not necessary because the residual risk of breast cancer after having a risk-reducing mastectomy is only about 5%. For prostate cancer screening, there are new recommendations in 2025. For BRCA2, because prostate cancer is more common in patients with BRCA2, it's recommended for men with a BRCA2 mutation to have annual testing with a PSA blood test starting at the age of 40, and to consider having a specialized MRI. And this is preferably done in a research setting because we're trying to gather data as to the necessity and effectiveness of doing these MRIs. For other genetic mutations of BRCA1, PALB2, CHEK2, ATM, and HOXB13, they also put the patient at increased risk of prostate cancer. And so the recommendation is to consider annual testing with a PSA from the age of 40. So they say absolutely should be tested with BRCA2 and consider testing with BRCA1, PALB2, CHEK2, ATM, and HOXB13. Pancreatic screening is a little bit tricky. Pancreatic cancer is a cancer that is oftentimes found in an advanced stage, is aggressive and difficult to treat. Some pancreatic cancer can be associated with hereditary cancer mutations, and people with hereditary cancer mutations may have an increased risk of pancreatic cancer. So it is recommended to do pancreatic screening, again, preferably in a research setting, if patients have a STK11 mutation starting at the age of 30 to 35, with a CKN2A mutation starting at 40, and with ATM and BRCA2 mutations starting at the age of 50. This pancreatic screening can be either a special type of upper GI endoscopy called an ERCP, or through a special type of MRI called an MRCP. For other people with mutations in BRCA1, MLH1, MSH2, MSH6, EpCAM, and TP53, you may consider pancreatic screening, but only if there's also a family history of pancreatic cancer present. Again, we recommend that these are done in a research setting. Some of the major academic centers in the Chicagoland area do have active pancreatic screening research studies ongoing. Our recommendations are really changing warp speed. Why are the recommendations changing so quickly in the field of hereditary cancer screening? It's because we've really just found out about these cancer-causing genes. BRCA was only identified 30 years ago. Many of our other hereditary cancer genes were found far after that. We haven't got decades of experience in understanding these genes. And so we are learning more and more as the years go on. So in participating in these research studies, you're not only getting appropriate treatment, but you're also allowing for researchers to gather this information to make these recommendations. There have been updates also in risk-reducing bilateral salpingo-oophorectomy. Salpingo meaning fallopian tube, oophorectomy meaning ovary. So by risk-reducing bilateral salpingo-oophorectomy is risk-reducing tubes and ovaries coming out. The guidelines have changed as far as some of the ages at which we recommend removing the tubes and ovaries. For BRCA1, it is at 35 to 40 years of age, as long as that patient has completed all of their childbearing. For BRCA2 and for the genes in Lynch syndrome, especially MLH1, MSH2, MSH6, it's recommended at 40 to 45. And in other mutations, PALB2, RIP1, RAD51C, and RAD51D, the recommendation is to remove the tubes and ovaries at 45 to 50 years of age. In all of these cases, hormone therapy can be considered to give patients back the hormones that they would be missing from becoming menopausal at an earlier age than the body had anticipated it would. We know that about 70% of ovarian cancer is thought to actually arise in the fallopian tube. The question is would it be effective to just remove the tube and not make the patient menopausal by removing the ovaries? So we know that opportunistic self-injecting at the time of hysterectomy for benign conditions does decrease the risk of ovarian cancer. Opportunistic means that when someone's having a hysterectomy for non-cancerous genetic reasons, fibroids, endometriosis, if we take out the fallopian tubes at the same time, we know that we slightly decrease the risk of ovarian cancer. But what about for people that have a hereditary cancer mutation? We have actually looked at that through some trials such as the WISP trial out of MD Anderson, and at least the initial findings are that there were no interval cancers noted between having the tubes out and then secondarily having the ovaries out. And perhaps there was less regret of not having the ovaries out at a younger age. However, there's probably a pretty significant bias in the people who chose to be in this study in the first place. So it may be reasonable at this point to consider taking out the tubes, fallopian tubes, first, and then taking out the ovaries at the appropriate times that were listed in this previous slide. If someone is unable to take birth control pills because of contraindication, or if they have finished having their babies, if their reproduction is finished prior to the guideline ages to have the ovaries out. Lastly, for me, there are some reproductive considerations that have been discussed this year with the National Comprehensive Cancer Network. When someone is known to have a germline mutation, a mutation such as BRCA, PALB2, ATM, Lynch syndrome, there is an opportunity for someone to, when they are considering to have when they're ready to have a baby, of undergoing IVF, making an embryo, plucking off one cell off of that embryo, and testing it to see if that mutation is present. And then if a mutation is present in a particular ovary, in a particular embryo, of not implanting that embryo and only implanting and letting a pregnancy go forward if there is not that particular mutation present. This is called pre-implantation genetic testing. There are other reasons to consider pre-implantation genetic testing, though, other than only implanting embryos that don't have a genetic mutation. Specifically in patients with BRCA1, they may have early egg aging, leading to infertility, age-related infertility at a younger age. We know that it's very difficult for a woman in her early to mid to late 40s to be able to get pregnant, even if they are still having periods, because of that egg aging. In patients with BRCA1, that aging happens at a much earlier time frame. The other reason to think about doing some IVF and egg and embryo banking is because fertility might be interrupted if a cancer diagnosis presents at a time when someone is of reproductive age. So in the case of BRCA1, about 50% of people who are going to get breast cancer are going to get breast cancer prior to the age of 50. In those patients, they will likely have to undergo cancer therapy. Hopefully that cancer is found very early because of the screening we do for BRCA1, but we're probably going to tell that patient we'd like them not to get pregnant for a period of time, oftentimes 5 years, after the diagnosis and treatment of breast cancer. With that delay, there is a possibility that that patient now is no longer able to get pregnant because of age-related issues. So egg banking and embryo banking is like an insurance policy to ensure the ability to create an embryo and to be pregnant after a cancer diagnosis. And lastly, if someone has a mutation in certain genes, the partner of that patient should likely be tested or should consider testing to see if they carry that same gene. Because if both parents have a particular mutation and both of them pass along that particular mutation to a child, there are illnesses that can be quite severe that can be associated with having two different copies of the same mutation. In the case of ATM mutations, if you have two copies of it, it is a disease called ataxia-telangiectasia, which is a severe neurologic condition. In BRCA1, BRCA2, BRIP1, MLH1, MSH2, MSH6, PMS2, EpCAM, PALB2, and RAD51C, there can be a disease called Fanconi's anemia, which also has pretty severe symptoms and shortened life expectancy. So when a patient is with a known mutation is considering reproduction, if they are not going to undergo pre-implantation genetics looking for that mutation, that partner may want to consider being tested to make sure they don't carry that same gene. And with that, I'm going to turn the microphone over to Scott Weissman to talk to us a little bit more about testing and about appropriateness of who should be tested, why they should be tested. Scott, take it away.
All right, great. Thank you, Dr. Snow. That was really informative, really great. Just because we're switching, can you see my slides now? Or do you see the presentation mode?
Yes, we see your slides.
Okay, great. So, based on some of the questions that we received this evening, we know that some of you have already undergone genetic testing, but there's some of you on the webinar that maybe haven't undergone genetic testing at this point in time. So there are several different criteria that exist that would make somebody a candidate to consider genetic testing. But high level, there are kind of some general red flags that may make somebody a little bit more of a candidate than others. So if you're seeing cancer in two or more close relatives on the same side of the family, more specifically, maybe the same type of cancer. If you're seeing people who are diagnosed with cancer under the age of 50, early onset cancers tend to be a little bit more of a concern for hereditary syndrome. Anybody who's had more than one primary cancer, so not a cancer that was treated and came back, but actually a completely separate cancer, or for organs where there are multiple, like two breasts, two kidneys. If each breast or each kidney has had a cancer, that can be a red flag, or less commonly seen cancers like male breast cancer. And we know that there are certain cancers that go together. So in some of the genes you heard Dr. Snow talking about, BRCA1, BRCA2, PALB2, RAD51C and D, those can really come with breast and ovarian cancer. We know that colon cancer and uterine cancer can travel together due to Lynch syndrome. Melanoma and pancreatic cancer can travel together sometimes. And then if there's evidence of autosomal dominant transmission, basically with dominant conditions, there's a 50-50 chance of passing it along in each generation. So if you're seeing a grandparent, their child, their grandchild, all with cancer, again, multiple generations, that can be an indication that something hereditary is going on. There are certain cancers, though, where you really don't need any additional family history. There are certain cancers where just having that cancer a lot and alone is enough to consider a genetic test because these cancers have been shown to have a high propensity for having a hereditary cause. Usually, you think about people that have these cancers, there's a 1 in 5 chance that they could test positive for hereditary syndrome. And a lot of these are rare cancer types. These are not run-of-the-mill cancers, but there is a specific type of aggressive thyroid cancer that's called medullary thyroid cancer, where anybody that has that diagnosis should be offered testing. There are head and neck tumors that are called paragangliomas, or on the adrenal glands. They're called pheochromocytomas. Those are actually benign tumors, but if they're left in the body and not treated, they can become malignant. And again, these are highly hereditary tumors. Retinoblastoma is typically a childhood onset ocular cancer. So any child that gets diagnosed with this tumor should be offered genetic testing. Cancer of the adrenal gland is a red flag. Urinary tract cancers. So there can be certain urinary tract cancers that may be a little bit more common, like bladder polyps in smokers. And these cancers are typically relatively treatable, but anybody that's diagnosed with an advanced urinary tract cancer, again, another indication. And then people who potentially have different types of early onset brain tumors or head and neck tumors that are called schwannomas or meningiomas should also be offered genetic testing, again, regardless of any family history. And as Dr. Snow has talked about, why it matters to identify whether or not there's something hereditary there can really allow people to take advantage of either increased screening or surveillance after a cancer diagnosis. There can be risk-reducing options that can be made available. I think most importantly, if you're screening for these cancers, ideally, you can identify them in earlier stages, which can lead to better overall outcomes. Again, as Dr. Snow talked about, it can really impact treatment decisions, certain chemotherapies, certain other types of therapies like immunotherapies or PARP inhibitors. It may change the surgical approach of a surgeon and how they're going to do a surgery. Or again, in some cases, it may change therapies. And for certain types of cancers, there may be therapies that a doctor doesn't want to give because they know they're not going to be as effective. So, example, for Lynch syndrome, there are certain therapies that are going to be less effective in treating the colon cancer and just give the individual more side effects from the chemotherapy without any of the benefit. So again, really a lot of important information for why this information is relevant to find out about it. I think the other reason why it can be important is that people who are identified to have a hereditary cancer syndrome, it does open up the opportunity for different research opportunities in terms of clinical trials. There is a lot going on in terms of specific therapies that, again, are still in the research phase, that aren't really kind of standard of care at this point in time, that are really being studied in individuals with the hereditary risk, because some of these therapies are really trying to take advantage of the genetic error for treating cancers. So, for example, for BRCA1 and 2, there's treatment trials looking at a combination of PARP inhibitors and immunotherapies. For pancreatic cancer, they're looking at different drug combinations to treat people that get pancreatic cancer to BRCA1, BRCA2, or a gene, again, that's called PALB2, which is very similar to the BRCA2 gene. There's cancer prevention trials. As Dr. Snow talked about, they have the IBs and the ABs in terms of the different medications, but there's a monoclonal antibody that they're studying in women that have BRCA1 mutations to see if that could potentially prevent breast cancer. You have trials looking at people that have Lynch syndrome. You're looking at different kind of over-the-counter medications that can be used to hopefully reduce cancer risk. And something that I think is particularly exciting for the hereditary cancer space is there are researchers that are looking at vaccines to potentially train the body to recognize and eliminate precancerous cells to potentially prevent individuals with Lynch syndrome from developing cancers. So this will be a really exciting development if this pans out to be true. Could this potentially play out for other hereditary cancer syndromes as well? For a little bit more rare of a hereditary cancer syndrome called Li-Fraumeni, they're looking at different MRI techniques to see if they could be a little bit more sensitive in detecting early tumors. With Li-Fraumeni, about 90% of people that have this condition can get cancer under the age of 50, and it can really cause various different types of cancers. So one of the screening techniques that's typically recommended in people that have this condition are whole body MRIs. And so, like I said, they're looking at different MRIs. The MRIs can manipulate the water in the body in different ways to get different images to potentially, again, identify cancer early. And then one of the other things I think they're starting to study just generally across all different hereditary cancer conditions are these multi-cancer early detection blood tests. These are blood tests that are looking at either kind of different genetic patterns in somebody's blood, or potentially looking for DNA that cancer cells may be giving off in the blood that could potentially lead to earlier diagnosis of cancer through blood tests, which we really don't have a lot of those currently available. So while some of these tests are on the market, and again, not advocating for these tests at this point in time, but because they're on the market and they're being offered to individuals who don't necessarily have a hereditary risk of cancer, there's several studies looking at, do these tests really help and improve cancer detection in people who are generally at a higher risk? Now, for those of you on the call that have had genetic testing in the past and had potentially normal genetic test results, one of the things that has changed around the time of 2012 is how the genetic testing is done. So if you were previously tested, it may be time to talk to your healthcare provider about being retested. Prior to 2012, the testing that we were doing was really single gene testing. So you came in, you gave your personal and family history to a provider. Based on the constellation of cancers, they would offer you BRCA1 and 2 testing or Lynch syndrome testing. And if the testing was positive, you were done. great, you had your answer. But if test was normal, then potentially they would offer you a second test or a third test. And this could take weeks and weeks to get done. It could cost thousands of dollars over the course of doing multiple tests. And many families were left without answers. But in about 2012, 2013, there was a major change where we started offering what are called multi-gene panels. And these are genetic tests that are testing for many different genes or many different cancer types in one test. One of the recent advancements over the past 4 or 5 years has been the addition of not only testing somebody's DNA, but also testing somebody's RNA, which can give the laboratory a sense of whether or not they missed something in the DNA analysis that makes them go back and look at a particular region of the DNA with a finer tooth comb. There's fewer testing options, which makes it, I think, a little bit easier for healthcare providers to order. And the cost of this type of testing has significantly dropped if people have to pay out of pocket if insurance doesn't cover it. Prior to 2012, these tests were $2,000, $3,000 a pop. Now these tests can be done for about $250. And what these tests are basically looking at are genes that could potentially not only cause a high risk of cancer, but also more of a moderate risk of cancer. So high risk of cancer may be somewhere between like a 40 and 80% chance of getting cancer. A moderate risk of cancer may be more in the 20 to 40% range. And these are all genes that are clinically actionable, meaning if you know you have a mutation in this gene, there's clear recommendations in terms of how your provider needs to manage you. Again, you can talk about those increased screening or risk reduction options. And then you can test other family members so that they can potentially find out, who's at risk and who may not be. These tests also include what I kind of call newer or lower risk genes, where these are genes that maybe have been more recently linked to a hereditary cancer risk, but it's more of a link. It's not a definitive cause. So some of these genes aren't fully actionable. We don't know the full risks or the full cancer spectrum. And so we really wouldn't necessarily recommend anything risk reducing or any surgeries based on these genes, but we may screen people more closely, or at least you have the information. So as the research progresses, you would know the significance of this gene to you. And also with these newer or lower risk genes, again, always not 100% sure whether or not other family members should be tested for them. So again, that's why if you're really going to consider additional genetic testing, it's going to be worth meeting with a genetic specialist who can talk to you more about the pros and cons of this kind of testing. So again, who should really consider this? Any individuals that have a significant personal or family history of cancer, individuals that have a cancer diagnosis where knowing if it's hereditary may influence the treatment plan. You can talk to your surgeon, your oncologist about this. If you have a family history or a past history of cancer and you're not really seeing your oncologist anymore, you can talk to your primary care physician, your OBGYN, and really ask for a referral to a cancer genetic counselor who can really sit down with you, map everything out, and figure out, what may be the best test for your situation. So through the Sarnoff Center, we're always here as a resource to answer anybody's questions about hereditary cancer, genetic testing, your personal and family history. So you're more than welcome to reach out to us with any questions or concerns that you may have. And so with that, I think I'm going to turn it back over to Sabina for some Q&A.
Thank you so much to both of you for this informative presentation. We do have a couple of questions that came in live and then some of our pre-submitted questions. So we'll do our best to get through as many as we can in the 10 minutes that we have left. Dr. Snow, you talked a little bit about the ability to test embryos and some of that kind of process. One of our questions is if a person has BRCA2 as well as multiple other low penetrance mutations, is it reasonable to try to screen for a mutation-free embryo, or are they just going to want to avoid BRCA2 and then kind of accept the presence of other mutations?
So it's impossible to answer that precisely because I don't know what those other low penetrance mutations might be. And I don't know if they are dominant, meaning that they would have to be present only in one parent to cause the disease in a child, or if it was something that was going to have recessive, both parents would have to have that abnormal gene, and both of them have to give it to that child in order for a child to be affected. If there is a complex history like both BRCA2 and other genes, I would strongly recommend seeing a genetic counselor to really understand the ramifications of each of these mutations and be able then to make a decision. It might be you just screen for BRCA2, could be that you screen for BRCA2 and one or two of the other mutations, but that's where you really need that individualized and very specialized care that a genetic counselor can give you.
Thank you so much. Scott, you talked a little bit about the kind of the circulating tumor DNA and that being used in testing. This kind of more of an opinion, how soon do you think we'll have kind of more superior screening tests to really search for the circulating tumor DNAs or liquid biopsies related to pancreatic cancer?
Yeah, so it's a very active area of research, and what's currently available tends to be more of these multi-cancer tests where it's looking at, several different cancers all at once. There definitely are specific companies that are targeting single cancers, with pancreatic cancer being one of them. That is a high priority for a lot of these companies. So, I think it's reasonable to think maybe within the next 5 years or so, we may see some of these tests coming to market. But I think it's just an exciting area about the possibility of potentially having something via blood that can detect pancreatic cancer early. Some of the current tests on the market, there are case reports of them finding pancreatic cancer stage 1 or stage 2, but I would say it's definitely not the norm with these tests.
Thank you so much. Dr. Snow, do you have anything to add to that?
No, that was exactly it. And I think that, though, stay tuned. I do think that we will be seeing something in the coming few to 5 to 10 years where we will have more.
Thank you both. The next question, with early onset colorectal cancer on the rise, should individuals with moderate risk APC variants, not Lynch, still wait until 40 for colonoscopy, or is this a case for earlier screening?
That's a great question. Yeah, colon cancer is definitely on the rise in younger individuals, which is why they pushed the screening guidelines back from 50 to 45 a few years back. The APC variant is known to cause about a 2 to 3-fold increased risk of colon cancer. And so the current recommendations are to start at 40, so that individual's, 100% correct. I haven't really seen anything showing that we're seeing earlier onset in people that have APC that would warrant doing screening earlier. But as Dr. Snow talked about earlier, the organization that is called the National Comprehensive Cancer Network, they meet at least a couple times a year to review anything that's been published since the last time they meet, so that when they're putting out screening guidelines, they're using it based on the most up-to-date information. So if that data becomes available and there's a difference, I think they would make those changes to the guidelines if relevant.
And actually, just this year, they reaffirmed that this is a low penetrance gene and recommended only 40, unless there is also a family history of early onset colorectal cancer.
Yeah.
So if there was someone in the family who had a earlier than 50 diagnosis of colorectal cancer, then you would want to talk to your provider about potentially starting just a little earlier.
Yeah, in genetics, we typically use a 10-year rule. You kind of start about 10 years before the earliest age of onset in the family. So if somebody was diagnosed at 40, you may want to start at 30.
Thank you so much. Those are our submitted live questions. Again, for those of you who are watching live, you're welcome to use our Q&A. Is there enough difference between the genetic testing done before 2012 and now that someone has known BRCA1 mutation and has had breast and ovarian cancer since the original test? Is there anything that they can gain from redoing the testing?
So it's a really good question. Typically, I would say the answer is no, unless there's cancer on both sides of the family. If there is what we call a bilineal risk, where there's breast or ovarian cancer on both sides, and you were only tested for BRCA1 and 2, it is possible that there's, BRCA1 on one side and something else on the other side that we just didn't test for. But if one side of the family is clearly BRCA1 or BRCA2, and that was what was found, and there's no cancer on the other side, usually I'm not redoing genetic testing at that point in time. I don't know, Dr. Snow, if you agree with that or have other thoughts.
Completely agree. If you've already found the one mutation, odds of there being a second mutation, unless it's a very unusual family history, or both sides of the family, I don't think it's worthwhile to go back and retest. However, the one thing that we do know is if you were tested for BRCA1 or 2, 1 and 2, and it was negative prior to 2012, and you have a strong family history, you should have repeat testing done, because even the BRCA1 and 2 mutation testing is improved and more comprehensive since 2012.
Thank you so much.
I
That is
believe
actually
in 2015.
very useful information. Can we talk a little bit about sort of risk reduction prevention? This pre-submitted question was, how much do genetics determine the risk for female cancers versus how much of it is lifestyle related?
So people with, say, it depends on the particular mutation. In people with BRCA1, there's a very high risk, up to 60 to 70% risk of breast cancer, up to 40% risk of ovarian cancer. In other genes, say a CHEK2, there's probably only about a 25% risk of breast cancer. So the type of mutation that you have is going to definitely make a difference as far as the actual risks that you have. Regarding lifestyle factors, some of the studies show about a 1.5 multiplier of the risk for certain lifestyle choices. That is probably small. If the average risk of breast cancer is, say, 13%, a 1.5 time multiplier may get you up to 16, 17%, 18%, but it's not going to get you up to that 60, 70% risk that a BRCA mutation has. Having said that, people with a mutation, it is even more important for them to consider lifestyle choices, because those lifestyle choices are added hits to the cause DNA damage that your BRCA mutation would not allow you to easily repair. And I hand it over to you, Scott, to
Yeah, I think the only thing I would really add to that is, if you have a negative genetic test and you have a family history, there are ways where risks can be calculated, like for breast cancer, or there are some guidelines that will say if you have a combination of certain things in the family that you may qualify for additional screening. And I think the lifestyle factors, diet, exercise, alcohol intake, are just kind of applicable to anybody, regardless of whether it's hereditary or not, whether there's a family history or not. Kind of making those good choices can all help reduce, cancer risk.
Thank you very much. Any updates to whether treatment or screening on triple negative breast cancer that you could talk about?
So I don't know specifically updates on triple negative cancer screening that is new in the last couple of years, but it goes without saying, since this is a genetic talk, that people that have triple negative breast cancer have a higher probability of being BRCA1 positive, and people with BRCA1, conversely, have a higher risk of triple negative cancer compared to the general population. So anyone with a triple negative breast cancer should have genetic testing done.
Thank you so much. And I'm mindful of our time that we're at 7:30, so I will ask one more question from the pre-submitted. For this one for Scott. Scott, can you talk about genetics related to testicular cancer?
Yeah, so that is one that has really kind of eluded us for years. So there are definitely situations where there is familial testicular cancer, dad and son, two brothers, three generations, and they have looked for different hereditary causes. And to this date, we really still don't have a single gene that's responsible. There's one gene called CHEK2 that's a moderate risk gene that's been linked in a few families that have familial testicular cancer. It seems like this may be more what we would call like a polygenic risk, where it's not a single gene, but it's a combination of multiple genetic risk factors that are inherent, that are causing an overall higher risk of getting it. So I think there's more to come, more research to do, but right now we don't really have a specific single cause.
Thank you so much. Okay, I would like this last question concluded our presentation for this evening, our lecture for this evening. Thank you everyone who joined us today for this informative webinar. Please note that you will all receive the recording as well as a program evaluation. We do ask that you take a couple of minutes to complete it and share your feedback regarding this webinar this evening. Thank you so much, Dr. Snow and Scott, for your time this evening, and Judah. And we appreciate the partnership with Norton and Elaine Center for Jewish Genetics. Have a great night, everyone.